So this chapter is about acetaminophen, otherwise known as paracetamol, otherwise known as Tylenol, in much of North America at least. What's it called? Panadol in England, I think. What's it called in Australia? Panadol. Oh. Yeah, so it's paracetamol, it's acetaminophen, whatever. But anyway, so the quick and dirty is, I would never go work for somebody selling something. So I think we shouldn't be working for drug companies. You can't do it without a conflict. But if I were ever to go work for a drug company, it would be for Tylenol, because it's the best drug there is. Now, of course, I'm being facetious, I wouldn't do it. But this is a really good drug. It's a phenomenal drug. It's a safe drug. It's very effective. How effective, I'm not exactly sure, because we've never really tested out exactly how effective it is. But for what it does, it's a terrific drug, and it's extraordinarily safe. And the only problem with Tylenol or acetaminophen is that it's too cheap. And because it's so cheap, it's subject to endless attacks. Every time a new analgesic comes along, Tylenol all of a sudden becomes dangerous again. And that's happened 3 or 4 times. So we have a couple of little topics to talk about. One of them is how safe is acetaminophen. So before we get to that, the first few articles say, when parents are dosing their kids for fever, for the antipyretic effect, if you tell them to do it by teaspoons or tablespoons, you're going to get trouble. And why is that? Because teaspoons are not any one size. We're all taught it's 5 cc's, but in fact it's anywhere between 2 and 8 cc's, and tablespoons between 5 and 15 cc's. So if you tell them tablespoon or teaspoon, big problem. Is that really true? It is true that tablespoons and teaspoons are different, but it's not. You're supposed to use measuring spoons and actually tell them what you want. And we should do that, and most of the time now they have these devices that they can do it. This is really not important, but it's not important anyway, because you can't give enough acetaminophen to hurt them, and the goal should be clinical efficacy. So the dose doesn't really matter. What matters is the kid. And if and the only reason to treat a fever, like we said the other day, is not the fever, it's to make the kid feel well. So if the kid isn't feeling well, you didn't have enough. And if he's feeling well, you're fine, and you're not going to hurt him. Now, how do I know you're not going to hurt him? So now we're going to go to, so yes, of course, you should, if you really want to give X amount, you should give X amount. You shouldn't use some measurer that's completely inaccurate, like teaspoons are. But again, I don't think it's really that important, because the goal is not dose per kilo. The goal is make the kid feel better. Now, how much do you have to give to make them feel better? And what are the limits? How safe is it? So we need to know 2 things. One is we need to know what's the effective dose. And is more better? For many things, more is more effective, but we can't give more because it's going to be too toxic. So 2 of the drugs that I would never use, one is colchicine. Colchicine is a very effective drug for certain things, but you have to give enough to kill the patient for it to work. No, the toxic therapeutic ratio is teensy-weensy. Since there are equal drugs for almost anything that you use colchicine for, I would never use it. I would never use it because it's too toxic. Some of you will remember we used to give colchicine for gout, and the way you would dose it is enough until the patient is sick as hell, and then stop. Because you knew that you had to make them sick before it had any efficacy. Another good example is the drug that probably the worst drug ever created, theophylline. Theophylline is a terrible drug. Well, it turns out it's really a very effective drug if you give them enough to make them really sick. But the toxic therapeutic ratio is you have to make them toxic before you get a therapeutic effect. So when you look at therapeutic doses of theophylline in asthma or anything else, it's completely ineffective. If you give them enough to make them vomiting and in agony, it actually does start to have effects on the beta airway system. It becomes a beta agent. It becomes very effective. It just can't use it. There's no way you can give just the right amount. It doesn't work. And there are a lot of drugs where it's not quite that bad, but where the ratio of toxic to therapeutic is very close. So you got to give just enough, but not too much. So DIG is a great example of that. Lithium. There's a bunch of drugs where you can't give you got to worry. There's other drugs where giving more doesn't make it better. What's an example of where there's a ceiling effect? What's a drug that is commonly used where giving more doesn't make it better? Ibuprofen, great. So ibuprofen is used for two things. Ibuprofen, I'm going to say, as NSAIDs in general. They're used for two things. They're used for anti-inflammatory purpose, and they're used for analgesic, antipyretic purpose. And in terms of their anti-inflammatory purpose, more is better. The more you give, the more anti-inflammatory effect you have. For analgesia, however, or for antiparesis, that's not true. So what is the ceiling effect you get where you give more doesn't work for ibuprofen? What's the ceiling dose? 400. Now, it's not the same for everybody, so there might be somebody who gets a little more. But in large studies, 400, you give more, all you get is more adverse effects for pain and for antiparesis, unless it's an anti-inflammatory effect you're looking for. So this is not in the chapter, but it's really important, it's related. Where do you want an anti-inflammatory? What are the conditions where NSAIDs really have special value because of their anti-inflammatory effect? In terms of their analgesic and antipyretic effect, there are half dozen articles in here which say antiparesis. What's the difference between acetaminophen and an NSAID? None. There's no difference. What's the difference between acetaminophen and both together? Essentially none. If you give both together, you get it lasts a little bit longer, an hour longer. Well, instead of doing that, give one, and then when you need it again, give it again. That's what I do. I don't see any reason to combine the two. So there's nothing special about NSAIDs for anti-inflammation. How about for simple analgesia, like for headaches, or like for back pain, or things like that? What's the difference between maximum dose NSAID and standard dose acetaminophen? None. I mean, any study, 40% of the patients will prefer the NSAID, 30% will prefer the acetaminophen, and 30% won't care. So basically, they're virtually identical. Okay? So where are NSAIDs special? They're special where you really need an anti-inflammatory effect. What are the three places where you need an anti-inflammatory effect? Colic. Good. So for colic, there's prostaglandin mediated. They have special effect in colic, particularly renal colic. It's never been proven for biliary colic, probably the same. Where else? Gout, rheumatic diseases. There you need not just NSAIDs, you need lots of NSAIDs or aspirin or whatever it is. There is an anti-inflammatory effect. And the third one is menstruation, menstrual cramps. There it's been shown that NSAIDs are much better, much more effective than acetaminophen. Now, it hasn't been tested for everything, so there may be others. But those are the three we know about. Where has it been tested where they've seen that there is no difference between NSAIDs and acetaminophen? Just about everything. So headaches, back pain, bone pain, fractures, bruises, Achilles tendonitis, osteoarthritis. It's an itis. It must be inflammatory. No. Most of those have no inflammatory component. There's no difference between acetaminophen and an NSAID. So now let's talk about, so if there's no difference between them, which one should we use? So we should say it depends on cost and safety, right? So cost, acetaminophen is incredibly inexpensive, but so is ibuprofen. Not quite, but almost as inexpensive, so that's not really important. What about among NSAIDs, by the way? Which NSAID's better? No difference. Right? There's no difference whatsoever, except two things, cost and adverse effects. And how do you know which one has the worst adverse effect? It's really easy. It costs more. The more it costs, the worse the safest one is ibuprofen. That's the easiest thing. So you're going to use an NSAID, I use ibuprofen. Okay? It costs very little. Okay. But I only want to use it where it's really better. So what about adverse effects? So acetaminophen, is, as we'll see in a second, is essentially risk-free, unless you take an overdose. And ibuprofen is really good. It's not that bad, but it's not that good, is it? There's something like 17,000 admissions in the United States per year for GI bleed from NSAID-related. That's a lot compared to acetaminophen. So personally, I cannot imagine any reason why anyone would use combination of the two, or NSAID preferably over acetaminophen, except for those three conditions we're talking about. Now, there are some things where it's never been tested, we don't know, like pericarditis. Okay, that sounds like maybe it would be inflammatory. You want to use it in that case, fine. But for things like headache and back pain and bone pain and all, why would we ever use these other drugs? Forget renal failure, just GI bleeds. How many of you have seen a child GI bleeding on an NSAID? How many of you see children? Because if you see children, I mean, I've seen a few of them. I've never seen that before there were NSAIDs. I've never seen it in any other circumstance. Not never, but almost never. So personally, I don't get it, why we use NSAIDs, except in those very, very, very limited conditions. Now, how dangerous is acetaminophen? And how effective is it? So let's go back for a minute to talk about numbers. What is the effective dose of acetaminophen? 10 per kilo, 15 per kilo, 20 per kilo. So what's the toxic dose on the Rumac nomogram? 140, 150, it's probably closer to 200. If you get in a toxic level of 140 or 150, how many of those people go on to liver failure? 3 out of 100. Well, that's actually not true. 3 out of 100 go on to bump their enzymes a lot. How many get clinically sick? Well, I can't really tell you because we mostly treat them. But before we treated them, we know that 3 out of 100 would get to bumping their enzymes. Before there was a treatment, what happened to those 3 out of 100 who bumped their enzymes? Oh, it's a good comment, but it's not exactly right. Okay, before we get to that though, let's say, so if they did bump their enzymes, 3 out of 100 would go on to die. So 3 out of 100 times 3 out of 100 is 1 out of 10,000 would go on to die if you go above the level. 1 out of 10,000. Of the ones who didn't die, what happened to them? The other 97 out of 100 who bumped their enzymes. They do fine. There is no such thing as chronic acetaminophen liver disease. When you have acute liver disease from acetaminophen, they get better. They all get better. It's not a chronic disease. So that's not to say we shouldn't treat them. We should. It's no reason. You have an overdose. The treatment is very safe and effective. Okay, but it's marginal benefit. Most people will do fine. It saves you some liver transplants. It saves some death, but mostly they do just fine. They would do just fine. You need 150 to be 150 on the nomogram, and to get to 150 micrograms percent, how much do you have to take? Well, it's really easy. Every milligram per kilogram you take PO, your level goes up 1. The nice thing about acetaminophen is everything's 150 or everything's 140. That's the dose of N-acetylcysteine. It's the toxic level, it's the toxic dose. So it's really easy to remember. For every one you take, milligram per kilogram you take, you go up 1. So if you don't want to get to 150, don't take 150 per kilo. Well, now let's think about toxic therapeutic ratio. Just said there are a lot of drugs where a little too much gets you over. This, you have to take 10 times what's the standard therapeutic dose of 15 per kilo to get to where you get to the level where you have a 3% chance of bumping your enzymes, and 3% of those would go on to have clinical consequences. So I've never heard of a drug that's safe. It's exquisitely, enormously safe. So what's the therapeutic dose? Well, somebody said 10, somebody said 15, somebody said, well, how should we decide what the dose is? Well, first of all, we have a lot of margin to play. 35 is incredibly safe. 50 would be pretty damn safe. Now, I don't know about if you took 50 per kilo 10 times in a row, but certainly one dose, we have a lot of room. So then the question is there a ceiling effect? Would more be better? Do we know? We don't know. Okay, so I can't tell you more is better, but I'm going to show you in a second why I think probably more is better. Before we get to that, what about chronic acetaminophen toxicity? Not you got sick and we know that gets better, but what about if you take 40 per kilo over and over and over and over again? There's a few articles in here which address that. Basically, the literature comes in 2 schools. The one school is, we looked at people who got liver transplant in our liver unit, and a lot of them were from acetaminophen toxicity. We had 40 cases over 23 years, and half of them were from acetaminophen toxicity. So then what question do you have to ask? How do you know it was the acetaminophen? So if you actually go look at that, it's pretty bizarre, because when you actually look at those case series, and there's one in here which actually looks at it, but mostly you have to go look yourself, what you find is that the way they knew it was acetaminophen toxicity was that they didn't have another obvious cause, and the person had taken at least one Tylenol. And in many cases, they only took 2 Tylenol. But they took Tylenol and they had liver toxicity. It must be acetaminophen toxicity. This is crazy. But I want to go to number, I hope I can find it. There's one in here where there's 22 cases where they went back and reviewed it. Help me. Oh, here it is, number 4. 32,000 kids in 62 studies of looking at Tylenol for more than 24 hours, not a single case of liver toxicity, not one. 62,000 kids, not one single case. But they found 22 case reports with 4 deaths of liver failure where the person had taken acetaminophen. They then went back and used this scoring system that they thought predicted how likely was it acetaminophen. They said less than half of them did they think it was acetaminophen. Okay, only 9. But I want to ask you this question. If it was all 22, how does that compare to 17,000 hospitalizations for GI bleed per year? There's essentially no evidence that this even exists, chronic failure from it. But if it does, if you took all the cases in all the liver units and that claim it from acetaminophen, it's a teensy number compared. This is an extraordinarily safe drug. By the way, you said, what about is it a kid or an adult? In kids, it's way more safe. And the reason for that is there are 3 pathways that you metabolize acetaminophen. And there's only one of them that produces the toxic metabolite, and that's the mercapturate pathway. And the mercapturate pathway, the middle pathway, kids don't use. So they don't build up the metabolite. So certainly up till about age 8, it's almost impossible to have problem from acetaminophen. But even in adults, the total number of cases is so exquisitely small that even if all of them are from acetaminophen, and I doubt that most of them are, if any of them are, it's an incredibly safe drug. So I personally think, let's not be stupid, we don't have all the information. I don't tell people to take 70 per kilo repeatedly. Let's be serious, let's not do that. Let's be a little reasonable. If you can take many doses, try to keep it relatively small. But what about the new notion that the FDA just said, and the manufacturer just said, no more than 4,000 a day. So here's what the medical letter says about it. They've done this again since we published this. But they said, there have been several episodes where a new drug is coming out where somebody said, all of a sudden, acetaminophen is terrible. And they got warnings, and everybody's worried, and the manufacturer said, so the medical letter in 2009 said, you know, we look to see, there's this new campaign saying don't use acetaminophen, chronic acetaminophen is really dangerous. And so we look to see, where's the evidence? And they said, you know what? We don't see any new evidence about this. So the last time we did a comprehensive review on this was in 2002, and since there's absolutely no new evidence on this, we're just going to reprint what we wrote in 2002. At usual doses in healthy people, there are no adverse effects. The weight of evidence is that acetaminophen does not cause hepatotoxicity, even in chronic alcoholics, and that it is the safest drug of all the analgesics in chronic alcoholics. In fact, if you look at the liver people, they say the safest drug in people with liver disease is acetaminophen.
You kind of wonder why they recommend, say, kids with fever. If the fever is not controlled by acetaminophen, they recommend, or many nurses and clinicians recommend alternating
Right.
acetaminophen.
So one of these things in here is one of the guidelines which addressed that. I can't tell you why people recommend that. It's totally irrational. But the guideline said, I don't remember which paper it is, said, don't do that. Why shouldn't you do that? A, because it's unnecessary. Remember, the goal is not to get the fever down. The goal is to make the kid better. You can make the kid better. Second, it doesn't add anything. It's not better to alternate them than to give one. It's not dangerous, and you don't get any more efficacy. And third of all, there's an adverse effect for alternating it. And that is that you're teaching the parents that you have to do this complicated regimen because it's really important to get the fever down. And we should be teaching them just the opposite. It doesn't matter what the fever is. Don't take the temperature. Look at Johnny. Is Johnny okay? If he needs more, give him more. Now the last little bit of this is, I don't want to overstate. There isn't evidence. I can't prove that 40 per kilo isn't dangerous, but I'm virtually certain it isn't dangerous. There's no conceivable reason to imagine it's dangerous. You have to get to 150 for it to be dangerous. Okay, don't take 40 per kilo every hour. Okay, I got that. Even that I'm not sure it's true, but I wouldn't do it. But certainly we shouldn't be worrying about, is it 10 per kilo? So then the question is 20 per kilo better than 10 per kilo? Well, I don't know the answer. No, it's never been studied, but there is new evidence. Oh, there are two pieces of evidence. One is there's old evidence that for antiparesis, more is better. There is evidence of that. 40 per kilo gets much more effect on fever. So when I say NSAIDs and acetaminophen are equal, I mean low doses of acetaminophen are equal to maximum doses of NSAIDs. If you gave more acetaminophen, you would have more antipyretic effect. But what about pain? That's the one I'm really interested in. Is it a better analgesic or worse? It's certainly not worse than the NSAIDs. Could it be better? So there's a new kid on the block. The kid is IV acetaminophen. You have 3 articles in here. We've done now 5 or 6 where they gave it IV. And they gave IV doses of 10 per kilo, or 15 per kilo. And what they found was that when you give it IV, the blood level is much higher than you give it PO. That's no surprise because you don't have a first pass liver effect. It doesn't get taken away. So you actually get a much higher dose. And how well does it work? Well, it works about the same. 1 gram of acetaminophen, which is for most people 10 to 15 per kilo, works about the same as 0.1 per kilo of morphine. 0.1 per kilo of morphine is not an ideal dose. 0.1 per kilo of morphine is the ideal starting dose. You should start with 0.1 per kilo. About 50% of people have very good analgesic effect with that. And the others need more. So what I do with morphine is I titrate it. If we don't use a PCA pump, I titrate it. I commit to start with 0.1 per kilo. If they're really, really frail and elderly, I might start with a little tiny bit less, but I can't think of the time I've ever done that really. And sometimes I start with more if I think I really need more. But 0.1 per kilo is fine as long as you're committed to 5 to 10 minutes from now, I redose you if you're not doing better because it takes only 5 to 10 minutes for it to work. So if you work in a place where you say, we're going to titrate and you know that the nurse is not going to give the second dose for another hour, it's not good. That's not where you start with 0.1. But if you can have it, really do it titrated, it's a great place to start. Realize it will fail in 50% of the patients in every study. 50% need more. But then on the other hand, 0.1 per kilo of morphine is not nothing. That's a lot better than ibuprofen, isn't it? I don't think 0.1 per kilo is the same as giving some ibuprofen. So if IV NSAID, if IV acetaminophen, which actually at 10 to 15 per kilo gives you about 3 times as much of the blood level, is very effective. Not perfect, but it's very effective. That would suggest to me that getting the same blood level orally would also be way more effective than 10 per kilo orally, or 15 or 20 per kilo. It's probably the equivalent to 35 or 40 per kilo orally. So I think there's pretty good circumstantial evidence that more would be much more effective. Now, when you give it IV, they claim it's safer because you're not getting that liver effect, and therefore that's why they can give a bigger dose to get a bigger blood level. And again, I can't prove it's safe to give it orally, but I'm pretty sure it's safe to give it orally. What I'm trying to tell you is that I bet that if somebody studied this, they would find that 40 per kilo of acetaminophen is far more effective than 10 per kilo or 20 per kilo. That it's not a ceiling effect. Maybe 50 is a ceiling, maybe 60, but it's not 10 or 20. More is better. So what do you do with that? I don't think we should use this. I don't think we should use IV acetaminophen. It's just costly. You don't need to do that. You should use morphine if you need that type of drug. On the other hand, I think it should tell us that if you want to treat mild to moderate pain with an outpatient analgesic, we could do a lot better than 400 of ibuprofen, which is the equivalent of 15 per kilo of acetaminophen. We could give them 30 per kilo. We'd probably have much better efficacy. Now, I'm not telling you to do that because every agency says you shouldn't. But I can't find any rational reason why you shouldn't. And some people I know actually do that. I don't want to name any names. I'm on tape here. But someone I know very well uses a much higher dose than 15 per kilo. Don't be cavalier about it. If they're going to be taken multiple times, don't do it. But I'm pretty sure that it's incredibly safe and that it's much more effective. The bottom line is, don't be using NSAIDs where there's no reason, and you can get really good results with acetaminophen, and it's incredibly safe, and it's even more safe in children. Okay, any thoughts, comments, questions? Anybody using higher doses?
Are you familiar with the case a few years ago of the college girl who died from liver toxicity, and the mother swore up and down that she had the flu and she was just taking maybe a little bit more Tylenol for her flu?
No, I don't know it, but so anything's possible. I think it's probably unlikely, but anything is possible. But remember, let's put this into perspective. How many doses of acetaminophen are taken out there every year? There's zillions, and there's almost no cases. If that case is true, so what? Yeah, bad things can happen, but it's probably not true. I think it's probably not true, but even so, even if it were true, 17,000 admissions per year for GI bleeds from NSAIDs. That's a lot more than one case. And I'm sure some of them died. Anyway, just something to think about. I'm not encouraging you to do what the package insert says you shouldn't do, but I am encouraging you to think for yourself about what seems reasonable. And there's certainly an in-between, give 10 per kilo or 15 per kilo and give 80 per kilo. I mean, I think we can do better than that. I never give less than 20 per kilo.
One of the common practices, if you get a patient who's on a transplant, liver transplant list, and they get fever for whatever reason, as opposed to giving acetaminophen, they encourage you to give ibuprofen.
Well, no, if you actually read the liver guidelines, they say the exact opposite. They say people with liver transplant and people with liver disease, the safest PO analgesic is acetaminophen. The NSAIDs are particularly dangerous in those people. They don't clot, they have lots of problems.
I have some off-label experience with the use of acetaminophen and ibuprofen together. I find that it works very well for musculoskeletal pain or simple pain that people come with years.
And I think, I can't speak to your anecdotal experience, but if I had to guess, I would bet it would be true that that's a testimony to your good effect, your good placebo effect as a doctor. Because in studies, it has no value. It's no different than giving just one of them. And, we should never write for placebo. We should always use placebo effect for value. We should never lie to patients, but we should always encourage them. If you tell them it's going to hurt, it's going to hurt. If you tell them, I really think this is going to work. This is, and the way I get really good placebo effect from acetaminophen, because they think I spent $200 to come to you to tell me to take Tylenol. So if you say to them, the reason it hasn't worked for you in the past is you haven't taken the right dose. Taking 2 Tylenol will never work. You need to take this. I know and then that has a big placebo effect. That's how it works. And then you can even enhance the placebo effect by then saying what I don't actually believe, which is don't take more than that. Be careful. Don't take 3. Only take 2 or whatever it is, because that makes it sound dangerous, and that, of course, tremendously enhances placebo effect. So I don't really think it would be dangerous if they took an extra one, but I tell them, no, just take what I told you. Yeah, so unless they have Kawasaki's disease, in which case you have to give them aspirin. Yeah. So when you think about medicine, and you think about what we do and studies to prove that something works or to prove something's dangerous, how do you know that when you jump out of a helicopter you should wear a parachute? Did somebody do a study about that? There's a famous joke, gag study in the Christmas issue of the VMJ, where every year they ask for gag things, and somebody wrote in proposing the helicopter study. We should see whether or not you should wear a parachute when you jump out of a helicopter. And he said, because we're told by all the EBM people that you only know something if it's in a study, that we obviously don't know this, they should be the subjects of this study. And just to be sure that they had the maximal effect, it should be a crossover study. So all the EBM gurus should get a chance to jump out without a parachute to find out. And the point the guy was making is obvious, which is that there are most things in life we know without studies, right? Most of our behavior in life, we don't study whether or not you should close your eyes when you're driving your car. That's crazy, right? Why is that? So we got to be humble. Many things we can be fooled by our anecdotal experience. On the other hand, when something's obvious, it's obvious. So most of the things we know, we do because it's not marginally better to wear a parachute. It's a lot better to wear a parachute than to not wear a parachute, right? Interesting. So when Fleming did penicillin, there never was a study to show that penicillin worked. You didn't need a study. It was pretty obvious. They were dropping like flies, and then all of a sudden, we're saving them. There's a big difference. Most of what we study is looking at little tiny fine margins. When you need 2,000 people to show that it's different, that means the difference is teensy. When you do observational studies, it's far worse. So yes, aspirin is associated with Reye syndrome. But you have to take 10 million doses of aspirin to have one extra case of Reye syndrome. So should you do it? If you have another choice, do the other thing. But is it dangerous? No.